Hey everybody's Gary Rogers, Noggin Doctor here from Great Falls, Virginia. It's a beautiful Sunday afternoon. I'm going to talk to you a little bit about congenital muscular torticollis. So, if anyone who follows our Facebook group knows, and I've written this in many, many papers, if you look at congenital muscular torticollis, it's the number one cause of head flattening, categorically, deformational head flattening. So, if you think about what causes a child's head to flatten, so 30% of kids will lay on their back, not 100%, 30% of kids will lay on their back will develop some form of plagiocephaly. Those numbers vary in the literature, and partly the reason they vary is because the way of measuring head asymmetry varies, and also the threshold for diagnosing plagiocephaly versus normal asymmetry varies author to author. But generally speaking, it's about a third of kids that lay on their back at either brachycephaly, which is just symmetrical flattening and widening of the head, or asymmetrical flattening called plagiocephaly, or deformational scaphocephaly, which is flattening of the side of the head that causes an elongated dolichocephalic head. So think about a third of kids laying on their back. That means that 70% of kids who lay on their back don't get flat. So what's the difference between these two cohorts of children? Well, the difference is the kids who get flat, it's not because the parents didn't hold them or because they neglected them or because they've left them in the containers too long. Everybody puts their kids in containers, car seats, things like that. That's not at all the case. The reality is those kids have a risk factor, and there are three major risk factors for plagiocephaly. The first one, the biggest one we're going to talk about today, is congenital muscular torticollis. That is a imbalance of the cervical muscles from positioning in utero. So it's a fetal constraint issue, and you can imagine child position in utero, this muscle becomes tight because the head's tilted over the side. This muscle becomes loose, it becomes atonic, and it's not able to contract. And you are born, and of course you have this imbalance that takes time to resolve, and sometimes it doesn't resolve if it's severe enough. Okay, so that's one risk factor, and I did a study in Boston that showed the co-diagnosis of torticollis that I could actually measure was about 92% of kids with plagiocephaly had a measurable head rotation difference side to side. So that's a pretty big number. The other reasons for getting head flattening are much less common, things like prematurity and things like developmental delay. So those are things. And the other one that might be thrown out there is iatrogenic, meaning kids that are in the hospital, physicianed, preemies, things like that, and we see that as well. So those are really the three, you can call it four if you believe some of my colleagues, reasons for getting flat. But the big one, the big daddy, is congenital muscular torticollis. There's no doubt this is the big one. So how do you see that in your child? Well, when a child's born, if they have congenital muscular torticollis, or some, you can call it whatever you want, cervical tightness, like, they tend to hold their head in one position. So that position could be midline, like this. It could be off to the side, which is classic torticollis. We think about muscle imbalance rather than symmetrical tightening, although it's the same mechanism. Their head was held one way in utero, held the other way in utero. Either way, it's tight. And you turn the child's head to one side, try to reposition, they go right back to it. Okay, you can turn the room around, you can change the mobile, you can breastfeed a different direction. All of these things have been deemed as risk factors for torticollis when in fact they really aren't, and for head flattening, they're really not. You can breastfeed on the other side, you can turn the whole bed around, you can turn the room around. A child with a right-sided head preference, strong right-sided head preference, will turn to the right side every time, regardless of how the room is situated. So that tendency to go to one position over and over is congenital muscular torticollis until proven otherwise. Okay, so how do you diagnose that, and how do you look at that in a child? Well, we just talked about the biggie, right? If every pediatrician wrote on their intake form, does your child have a preferred head rotation position, we would be able to diagnose and detect almost all the kids who have congenital muscular torticollis and all the kids who will eventually become flat or have the risk of getting flat, because that is the major risk factor. So continual head preference despite attempts at repositioning is a very clear indicator of congenital muscular torticollis. Other ways you can diagnose to confirm that is you can check head rotation. Now, you can't do that passively. So some papers, some studies look at head rotation where you turn the head, the doctor turns the head to the side, a clinician turns the head to the side, and says, okay, they got good range of motion. Well, even an arm that's your arm is contracted, I can pull you out to length. It doesn't feel good, and you're not going to do that voluntarily. That's passive motion. That is not the way to check this. The best way to check this is with active motion. So even a 3 or 4 week old child can be stimulated to look side to side if they're able to. And so you can manipulate either with keys or with some kind of noise or the mother's voice and have them look side to side and see how they do it. Now, if they can turn to what was thought to be the tight side and then rapidly go back to the other side, I would argue that they still have evidence of congenital muscular torticollis. They don't feel comfortable that way. They may eventually feel comfortable that way, but they don't at that time. And so they're going to always go back to the comfortable side. Well, that's going to bias them to a head position, and ultimately that will make them get flat. As their head lays against the bed in one spot over and over and over again, it's Newton's law, equal and opposite forces. The bed exerts an opposite force to the head will grow around the bed. So it's not that the head is soft. That's an old myth. The infant cranium is soft. Yeah, you can push on it, but it just springs right back. I can tell you, I operate on the infant cranium, so I can speak to this with with a lot of experience. And I've taken pictures of kids on MRI scanners. The head does not deform like a water balloon placed on a table. It's through growth that it gets flat. And so that's why we see kids with developed plagiocephaly over the course of 6 to 8 weeks. It starts off. People say, oh, they had it when they were born. There's been studies looking at that. The old chicken and the egg hypothesis. They got flat, and then they lay on that side and they get flatter. And the studies have shown unequivocally. Van Villemering and the group out of Sweden showed that's not true. That the kids who are flat early on in life are not the kids who are flat at 7 weeks. So whatever happens in utero is not going to propagate postnatally unless there's a tendency to go to one side, go to one position. External force continues to restrict growth in that direction, and they grow around that point of obstruction and develop the asymmetry. Okay, so that's the basic construct. So if you think about congenital muscular torticollis, here's what you need to understand is that the mild cases, kids that are almost undetectable by most clinical people, they resolve 3, 4, 5 weeks. They have a head bias early on, but they resolve that. Those kids are never going to come on the radar. Most pediatricians, most clinicians don't even, some physical therapists, frankly, physical therapy sides don't even consider that congenital muscular torticollis. And I would say I would beg to differ. It's just on the spectrum of severity. That's a very mild situation. That's a very mild case. Those kids, again, 3, 4 weeks may resolve it. Head bias is gone, and ultimately those kids are probably at very low risk for getting flat. Kids that are in the moderate range, where that muscle imbalance is more significant, may not resolve that early, and so they will continue to favor a side. You try repositioning. This is why repositioning fails, by the way. Repositioning works great for kids that don't have risk factors for getting flat, that we're never going to get flat in the first place. It doesn't work so great when you're dealing with congenital muscular torticollis. So turning the child's head, they go back. So a child with moderate torticollis is going to end up going back to that position over and over and over the course of 3 or 4 months, and ultimately they will become flat. And then you have kids that are very serious. So this is a spectrum from very mild, almost undetectable, all the way up to very severe fibrotic muscle, scarred muscle, pseudotumor, things like that, which those kids may never resolve. I have kids that have come to my office 7, 8 years of age and have head tilt, can't rotate to the ipsilateral side, and they've been doing therapy since they were babies. Okay, the therapy can't resolve a fibrotic or scarred muscle. That's a muscle that needs to be released, and in my experience, releasing that at about 18 months or 2 years makes sense if the rotation is still off. Now, this gets back to the diagnosis. How do you diagnose in a 6-month-old kid if the tight muscle, which is the one we worry about, really, the weak muscle will always build up tone with time. The tight muscle may not resolve, so we need to make sure the tight muscle gets resolved so the weak muscle can build up tone and works its way out. The way to look at tight muscle development is rotation. If you can rotate to the other side, to the tight side, 80 degrees, 75 degrees, normal head rotation with the shoulder stabilized, that muscle is not tight. Okay, that doesn't mean a child won't tilt, because the tight muscle often resolves long before the weak muscle builds tone. That's a truism. If you think about, again, putting your arm in a cast, if I put your arm in a cast for 6 to 8 weeks and you come out in flexion like this, your bicep muscle's contracted, your tricep muscle's on stretch as weak, and you come out, the first thing you're going to have to do is you're going to have to resolve the contraction of the bicep muscle, the tightness of the bicep muscle, before you can really build strength in the tricep and the rest of the arm. You have to regain the motion before you get the strength back. That's just a physical therapy truism. And so I would say that, can you have a child that has great head rotation, i.e. they've worked that neck out, or they've worked it out through therapy, or worked it out on their own, however they've done it, and still have a head tilt? Absolutely. And in fact, I see this all the time. Kids will come in with a head tilt, particularly when they're tired, when they're walking, when they're eating, doing things, they're reaching milestones. They will start to tilt again, and parents will think they're regressing, that the therapy is regressing, and that the torticollis is regressing. It's not regressing. They just are manifesting it because now they're preoccupied with something else, and this weak muscle is still mildly weak. It takes a long time for some kids to fully resolve that muscle imbalance, but they do. Over time, they will eventually do that with the right tone, as long as the tight muscle has resolved itself. Okay, so those are really the basics. The basics of congenital muscular torticollis. I will put in there that people always confuse congenital muscular torticollis with other causes like ocular torticollis, which is an eye muscle imbalance. It causes almost a pure head tilt. Hemivertebrae, which are cervical anomalies that cause the head to tilt to one side. They usually don't have the twisting. So if you look at classic congenital muscular torticollis, it's tilting, rotation, tilting the ipsilateral or tight muscle, rotation of your head to the contralateral side, and chin point up. Right? So the muscle here, as it contracts, does this kind of motion. Okay, that's the classic posture. Do all kids manifest that? Absolutely not. That's a fairly tight sternocolumnostic muscle. Some kids it's much more subtle, much less obvious, and that's sometimes why pediatricians may not pick it up. The other thing is when a child's laying on their back and they haven't been able to balance their head against gravity, they may not manifest a big tilt, particularly in mild cases. So what we hear about a lot of times is kids will be going along, and at 2-3 months they start getting up and having getting some head control, and they're tilting, and the parents say that they've acquired the torticollis. No, the torticollis was there early, and what's happening is now that you have the weight of the head to balance, that's the weak muscle now is becoming fatigued. The good news is about that is that that's exactly how you build tone. By challenging the muscle, by making it support the head weight. The worst thing you could ever do is put them in a talk collar, which is what some people do, to support the head. In what situation where you're trying to build strength and tone would you ever put somebody in a support that offloads the muscle? That's the worst thing you can ever do. You let them balance it, let them work it, and they will resolve it much quicker. We even have this, there's also this hypothesis once about helmeting, that putting the additional weight of a helmet on the head, which often makes the torticollis look worse, the head tilting look worse, because now you're balancing the weight of your head and a helmet, was beneficial to resolving torticollis, or at least the weak component, because you're now weighting it down. It's like adding weights on the barbell. You're working it more. I don't think it's ever been studied, and it'd be an interesting thing to look at, but it is an idea, and I think parents get alarmed when helmet goes on, and that they're helmeting at 6 months, and all of a sudden the head is tilting. It doesn't mean your baby's going backwards. It just means that now they have more weight to balance. The weak muscles now manifest, is exposed as being weak. And guess what? It'll build up tone over time. Okay? So that's instruction for today. Good to see you guys. Take care. Bye-bye.